Hello, everyone. This is Miss Cole. I'm here today to talk on the concept of elimination. Please bear with me as my voice is still getting over being sick. But this PowerPoint is going to be solely on urinary elimination, and then we will do a separate lecture on bowel elimination. So let's go ahead and get started. This is just an overview of the reading materials for the concept of elimination. I have provided you all with page numbers because some of the chapters jump all over the place. So you will see that you need to review chapters 38 and 39 in your fundamentals book, and then several different page numbers in your med-surg book. You are responsible for reading this material in addition to this PowerPoint. So the very first question is, well, what is elimination? It is exactly as it sounds. It is the body's way of getting rid of waste products that we do not need. So we do this through two body systems. We do it through the urinary system, which excretes urine that controls our fluid waste products, and the GI system, which is done through the bowel, mainly the large intestines, and that gets rid of our solid waste products through our stool. All right, so before we deep dive into urinary elimination, we need to discuss some related concepts to elimination. So first we have fluid and electrolytes. The kidneys play a vital role in fluid and electrolyte regulation. So our hormones have a job of balancing our fluid and electrolytes, but also our intake. So we know if we are drinking more fluid, we are more likely to urinate more versus if we are drinking less fluid, we are less likely to urinate. Also, our kidneys play a role in balancing the pH of our blood and body, which we will learn more about in another unit. Nutrition is another thing that can affect elimination. We know our water and food intake directly affects it. We become dehydrated when we don't drink enough fluid, and therefore we decrease our urine output. Versus if we are overhydrated, we are going to increase our urine output to get rid of that extra fluid. Certain foods can cause GI upset, diarrhea. We also know if we don't drink enough fluid that we can have constipation. And if we do not eat enough fiber in our diet or we have a very poor diet, that can lead to constipation as well. Mobility can also affect our elimination process. Decreased mobility can cause stasis of urine and stool. So our clients that are paralyzed, have had a stroke, maybe a spinal cord injury, or have some something that has made them bedbound, they may have trouble controlling their elimination or getting up in time to make it to the bathroom. We also know that if we don't move our bodies, everything slows down. That includes those urinary and GI processes. So if we move less, we are more likely to have urinary retention and constipation. Finally, one a lot of students forget is cognition. So our clients have to be able to feed themselves and drink enough fluids. If they have dementia, they may forget to eat or drink. They also need to be able to recognize cues for elimination. If they cannot recognize that they need to use the restroom, they are going to end up having incontinent episodes, or they may not be able to cognitively or safely get themselves to the restroom. All right, so we are going to go ahead and get started on the urinary elimination concept. All right, so this slide is just an overview of the A and P of the urinary system. So the urinary system consists of the kidneys, or two kidneys, the two ureters, bladder, and the urethra. So we know that urine begins in the kidneys. Our kidneys filter our blood and keep what we need and excrete what we don't and make it into urine. The urine then travels through two ureters, one on the left, one on the right, and the bladder serves as a storage almost balloon-like structure that holds our urine until we are ready to go to the bathroom and pee it out. And then the way that the urine leaves the bladder and exits the body is through the urethra. It's important to remember that the urethra is very different in males and females. Our female clients have a much shorter urethra, which puts them at a higher risk for infections like UTIs versus a male client that has a longer urethra. All right, so this slide has some key terminology that you will see throughout the urinary elimination lecture here. These words you will also see on tests on the NCLEX and in your charting. It is important to use the right medical terminology when charting, but make sure when you're actually speaking with your clients that you use words they can understand. So I'm going to go through these terms. Just make sure that you do fully understand them. So urination, we know, is the process of emptying the bladder. There are many different words for urination. You might also hear micturition or voiding. Urinary incontinence is the involuntary loss of urine. Stress incontinence is the involuntary leakage of urine because of increase in intra-abdominal pressure. So we see this a lot in our older female clients or our female clients who have given birth, as they might have some incontinence when they cough, sneeze, laugh, things like that. Urinary retention is when urine is produced normally, but it is not excreted as it should be from the bladder. Nocturia is the need to wake up in the night to urinate. Polyuria is excessive urination. Oliguria is urine output less than 400 milliliters in 24 hours. Anuria is urine output less than 50 milliliters in 24 hours. So anuria, or a patient who is anuric, essentially produces little to no urine. So think about, we might see that in a end-stage renal or dialysis patient. Dysuria would be painful urination. Hematuria would be blood in the urine. Urgency means a client has a strong desire to void and it might come on suddenly. And then proteinuria means protein in the urine. So, like I said, make sure you can identify this terminology and know what it means, because it may be the difference between understanding a question or a client's condition and not understanding it. All right, now that you've thought about that, let's discuss it. So there are several factors that can alter the elimination process. We know that the very first one is developmental status. We know that infants and newborns cannot control their urination, right? So voluntary control of the urethral sphincter usually occurs between 18 and 24 months. This is not a steadfast number. It changes based on the pediatric client. You may have a child that starts controlling their urine sooner. You might have one that starts controlling it later. You need to make sure that you are letting your parents or your caretakers know that just because another child already has bowel and bladder control does not mean that something is wrong with their child. But for testing purposes, we are going to say between 18 and 24 months. We also need to think about age. As we age, we tend to have more problems with our urinary elimination process. We tend to have more nocturia, so our clients are having to get up at night. They may not be able to sleep through the night. They're going to have decreased bladder tone and bladder contractility. We know that muscles tend to atrophy with age, and they may lose the ability to control their bladder. Cognitive alterations become common as we get older. We might have clients who develop dementia, Alzheimer's, have strokes, things like that. Mobility alterations are more common as we age. Our clients tend to get tend to get arthritis in their joints, which makes it difficult for them to move. They may have a stroke as they get older. They may start having spinal issues, things of that sort that make it difficult for them to move. And then our health alterations. We know that chronic conditions such as heart failure, diabetes, kidney disease tend to increase with age. Our activity and muscle tone, we've kind of discussed already, but we know that immobility is going to cause stasis of urine. We also know that the less we work muscles, the more likely they are to atrophy. So if we are not moving and doing pelvic floor therapy, Kegel exercises, that we can lose bladder tone, especially our female clients who have been through childbirth, menopause, or if we have a client who has had a significant trauma that has injured their pelvic muscles. Also, it's important to know long-term use of indwelling catheters can increase the risk of loss of bladder tone. So, what I like to say is that the bladder essentially becomes lazy. If it has a catheter in it for too long, it no longer contracts and holds the urine like it should, because when a catheter is in, it doesn't need to hold on to urine. The catheter does all the work for it. So if our body becomes used to that catheter in place, our bladder is going to become lazy and it will atrophy because we are not using it. We also have to think about psychological variables. We might have some culture that we need to consider. There are certain cultures that have different privacy and dignity issues. Stress can change your urinary elimination. We know that we are stressed, we might go to the bathroom more often. And then if we are embarrassed, there are clients who have issues with going to the bathroom and will actually have episodes of incontinence when they are embarrassed. All right, so continuing on with factors that affect urination. Like we mentioned when we started this lecture, we know food and fluid intake are going to affect urination. If a client is dehydrated, they are going to urinate less because the body and kidneys are compensating by holding on to fluid. Versus if we have a client in fluid overload, they are going to urinate more to get rid of that fluid. Alcohol intake. So, alcohol is a diuretic. The more alcohol that a client intakes, the more likely they are to urinate. Foods and drinks high in sodium. So, water follows salt. So, if we eat a lot of sodium or drink a lot of sodium, we are going to make more fluid and therefore urinate more. Foods that might change the color and odor of the urine. We have to think about certain diets are going to affect what our urine looks like. So, certain foods like beets, asparagus, things like that can affect the urine. There are multiple pathological conditions that can affect urination. Any disease that affects the renal or urinary system will affect the urination process, especially your chronic kidney disease. As these clients near the end stage renal disease process, they may stop making urine altogether. Also, if they have a UTI or a kidney infection, they may urinate less or more, depending on how advanced the disease process is. Diseases that affect the neuromuscular status or mobility. So, our spinal cord injury patients, stroke patients, any kind of paralysis type situation can cause alterations in urination. Also, brain injuries can affect the ability to control urination. Heart failure, we know these clients tend to be in fluid overload. So the more fluid they have on their bodies, the kidneys are going to compensate by getting rid of that. If a client has a fever or is sweating a lot, they may become dehydrated and pee or urinate less. And then diabetes. What is a main symptom of diabetes? It's something called polyuria or excessive urination. So our diabetic clients will urinate more. They may also have glucose in their urine if their blood sugar is high. Finally, there are several medications that can affect urination. There are medications that we consider to be nephrotoxic, meaning they are toxic to the kidneys. Those would be your NSAIDs or your non-steroid anti-inflammatory drugs. Those would be our naproxen, ibuprofen, aspirin. A lot of our over-the-counter pain medications can cause kidney damage if they're taken for a long period of time. And then certain antibiotics, especially the mycin antibiotics, that's going to be your vancomycin, gentamicin, things of that sort can cause kidney damage. So you will learn later down the road that if you are administering a antibiotic like vancomycin, you have to monitor the blood level, which is called a trough, and monitor their kidney function pretty closely when they're on those antibiotics. Diuretics can affect kidney function. There are diuretics like furosemide or Lasix we know are going to increase urine output. That's how we know they are working. And they can also impact renal function. We have cholinergics and anticholinergics. So, cholinergics will increase urination and make you urinate more versus anticholinergics that are going to make you urinate less. So, anticholinergics dry everything up. I want you to remember this little rhyme. It is not the most appropriate, but it will help you remember anticholinergics and what they do. So what they do is you can't see, you can't pee, you can't spit, and you can't SHIT. I'll let you figure the rhyme out there. So it's going to dry everything up. So we're going to give these anticholinergics to our clients that are over urinating, or maybe they have incontinence, bladder spasms, things like that. You would not want to give anticholinergics to our clients that have urinary retention because it would further that problem. We also have some medications that may change the color of the urine. Our anticoagulants, or people know them as blood thinners, may cause bleeding, and you might see that blood in the urine. That blood might, or excuse me, that urine may turn pink or red, and that is abnormal. So if a client that is on anticoagulants reports red or pink urine, or you as the nurse see that, you need to notify the provider. Something's going on there. We also have a drug called fenzopyridine, excuse me, that's a hard one to say. It's commonly known as pyridium. It is a urinary analgesic. So what it will do is it will numb the urinary tract if we have a client that is having like spasms or pain with urination. And it's given a lot of time in our female clients who have UTIs. It's important to make sure they know it will turn their urine red or orange, and it will actually stain things like the toilet seat, their underwear, things like that. Amitriptyline is an old antidepressant that can actually be used for incontinence. It helps with bladder spasms, but it can actually turn the urine green. There are also B complex vitamins that can turn the urine green. So in nursing school, I always remembered amitriptyline makes the urine green because that rhymes. And then finally, we have a medication called levodopa, which is used in our Parkinson's patients. And it can make the urine brown or black. There are also some types of iron supplements that can make the stool or urine brown or black. So it's important if you have a client on any of these medications that you know this because it may just be a side effect of the medication, because I know I would certainly panic if my urine turned green. So we want to make sure that our clients know if they're on a certain drug that that may happen, and that is a normal side effect of that medication. All right, so you all have already had a lecture on the urine or the assessment process. So I'm just going to run over the urinary assessment again and point out some pertinent information that you need to know. So we always need to take a good history and interview. We want to ask their voiding patterns, their voiding habits. When did they go to the bathroom? How often did they go to the bathroom? What is the problem? How long it's been going on? We also want to assess their bladder so we can palpate it. Is it tender? Is it distended? If we cannot determine that by palpation, we can use a bladder scanner, which is just a ultrasound machine to assess how much urine is in the bladder. Like I said in the previous slide, we do want to assess the ureteral meatus for any inflammation, discharge, or odor that could tell us about some kind of infection going on. We want to look at the skin around the perineal area. So that can tell us our hydration status. It can also tell us if they are having incontinence, they might be having excoriation or skin breakdown. It's also important to note what the urine itself looks like. So anytime a nurse is going to empty a urinal, a bedpan, a commode, or help their client to the bathroom, they should be assessing the urine. So you're looking for color, odor, clarity, any sediment. Sediment would be what falls to the bottom of the urine, such as debris, blood clots, crystals, things like that. We want to monitor the pH and specific gravity. That is something that you do have to have a test strip for, or you can send it to the lab for urinalysis. You might also monitor for things like glucose, protein, ketones, blood, and bacteria. The blood might be visual if there's a large amount of blood, or you may have to send it to the lab for a urinalysis. Of course, remember you will have to have an order for a urinalysis to do that. But there are a lot of things that the nurse can see with just their eyes. So make sure you are always looking at the urine. All right, so we're going to continue on the urinary assessment and talk about measuring urine output. It is the nurse's responsibility to measure any intake and output if that is ordered for that client. You might also hear this called I's and O's. It can be delegated to an LPN or a UAP, but you as the RN must make sure they know how to measure it properly and that it is being documented and followed up on. So why do we measure urine output? Why does it matter? Well, our urine output can actually tell us a good bit about kidney function and a patient's overall health. In fact, it has been shown that urine output can be one of the first indicators of shock, hypotension, and things of that nature. So normal urine output should be around 30 to 50 milliliters an hour. So that tells us that the patient should be making at least 30 milliliters of urine per hour. And if you choose to go into a critical care setting one day, you might actually be measuring hourly urine output to make sure their kidneys are functioning properly. So, for example, if you have a client who over, let's say, a 10-hour time period put out um, 300 milliliters of urine, what would that tell us? Well, we're going to take 300 milliliters divided by 10 hours, which would give us 30. So they are at least putting out 30 milliliters of urine an hour, therefore their kidney function is okay. Now, if we had a client who only put out 100 milliliters of urine in 10 hours, we would say 100 divided by 10 is 10. That would mean only 10 milliliters of urine an hour, and we would be worried that something is going on with their kidney function. It's also important to note that if you see a decrease in urine output, that's something you need to investigate and find out, are they holding on to the urine or are they just not making enough urine? So how do we calculate intake and output? Well, our intake is going to be anything that the patient puts in their body that is in liquid form. So water, juice, milk, soda. It's important to write down how much of it they drink and what the measurement is. So you have to remember your conversions that you will learn in the math section coming up in lab. But I'll go ahead and let you guys know there's 30 milliliters in 1 ounce. So keep that in your mind because it will come back. It's also important to note that if you have someone eating something that goes liquid at room temperature, like ice or a popsicle, we do count that as intake as well, but we only count it as half the normal amount. Like I said, you guys will get some practice with that when we get to math. And then output is going to be anything in liquid form that the patient puts out. So that might be GI secretions, vomit. For this section, it's going to be urine. So, how do we find out how much they put out? We measure it. For our continent patients, that's pretty easy. We just give them a collection device and we measure it and then we discard it. That could be a specimen hat, a urinal, a bedpan, etc. In fact, if they're cognitively aware enough, they can actually measure it themselves and write it down as long as they know how to do so properly. Always make sure when you are measuring a liquid that you sit it on a flat surface and get eye level with it so you can measure it properly. It is a little more difficult with our incontinent patients because we don't exactly know when they are going to void and they can't always tell us. So it may be a little more difficult to get an accurate measurement. We can offer scheduled toileting every 2 hours for these clients and measure their urine output that way. We can also put on external catheters that we're going to talk about later. They help collect the urine without actually having to put a catheter in their body. Or you can weigh absorbent pads. So you can place pads underneath the incontinent client. You would get a baseline measurement of a dry pad and then weigh your wet pad and subtract the difference. And then it is important to note that indwelling catheters cannot be placed just for intake and output purposes unless they need to be very closely monitored, like in a critical care setting. And remember that you do need an order to place an indwelling catheter. If they do have an indwelling catheter like a Foley, then we have to measure it through the collection bag. So what we'll do is we'll take the collection bag. There's a spout on the end of it. You'll unclamp the spout and empty it into a collection device like a urinal or a graduated cylinder, something that has measurement levels on it. It's always important to make sure that when you are measuring that you use a clean device. Don't ever touch the spout to the ground or the collection canister that you're using. You want to keep everything as clean as possible because when you're emptying that, you are increasing the risk of bacteria getting into that catheter. And then when you're done, make sure you clean the spout with alcohol and clamp it back. And then always make sure that that bag stays below the bladder so that it drains properly. We're going to talk more about that coming up, but that is the way you would measure from a Foley catheter. Right, so we're going to talk about specimen collection. So you as the nurse will be asked to collect urine specimens from your clients. A lot of these specimens can be done by the client themselves, but sometimes it does have to involve the nurse as well. So for a routine urinalysis, this is just going to be a standard test where they're looking at the urine. They may be looking at glucose, blood in the urine. They may be checking a urine drug screen. They might be checking a urine chemistry, specific gravity, different things like that. So this sample does not have to be sterile, and you can simply give the patient a clean collection device like a urinal, a cup, a bedpan, specimen hat, and have them void in that container and then give it to you to send to the lab. If they go in a bedpan or a urinal, just make sure that you pour it into a sterile cup before you send it to the lab. If you are checking for something like a culture or bacteria, this is going to be done through a clean catch. It's also known as a midstream collection. This is going to minimize the amount of bacterial contamination in your sample. And it is the closest we can get to a sterile specimen without actually catheterizing them. So the way we instruct our client to do this is first we're going to have them clean with an antiseptic wipe. Those are usually provided for them in the pack, the cup. And they're going to clean their perineal area. So women we know will wipe front to back. We're going to have them void a little bit in the toilet first. That's to flush out the bladder. And then they will collect the urine midstream. Once they've collected enough urine, the rest of it can be voided into the toilet. And then they're going to give it to the nurse. And then if we need a true sterile specimen, we are going to have to do a straight or an in and out cath on these clients. So an in and out cath, you'll see more on a future slide, but it's just a 1 lumen catheter that inserts into the bladder. It drains the urine that we need, and then we pull it out. We don't leave it in. It is important to note that you can take urine from a Foley catheter, an indwelling catheter, but you cannot collect it from the collection bag that's sitting below the bladder. You're actually going to collect it from the tubing. So when you have a Foley catheter, there is a area to swab and insert a syringe to draw out urine. There is a nursing care 38-2 in your book that explains that further if you'd like to look at it. Always make sure that once you've collected any urine, you place it in a sterile container and you label it in front of the client and place it in a biohazard bag. You never want to collect more than one specimen from a different client because you could cross-contaminate or mix up the samples. So make sure that you send your sample down before going on to another client to get a sample. A couple of FYIs, if you have a client, a female client that's menstruating, make sure you let the lab know that. Tell your client to not place any wipes or toilet tissue in the sample, and that if they need to have a bowel movement, they do that separately and not so that it does not contaminate the specimen. We also want to make sure when we give them a cup or a urinal, bedpan, whatever, that it is clean and has not been used before so that we get the most accurate sample possible. And then if you work somewhere where you don't have direct access to a lab, that you refrigerate or ice the sample, however your lab tells you to store it until it can be sent to the lab. And then I do want to note here that if you're going to be collecting a urine culture, which is going to grow out bacteria to see if they have an infection, that has to be a sterile or at least a clean catch because we want to get the most accurate results possible. Continuing on with specimen collection, these are some other options you may see in order to obtain a urine specimen. It's just going to depend on your client's needs. A urinary diversion, also known as a urostomy, is where they bring an ostomy to the outside of the abdomen and it drains their urine into a pouch. They may use this if a client has bladder cancer, obstruction, things like that, where their bladder is no longer able to hold their urine. So if it is a non-sterile sample, you could take it from the pouch directly. If it needs to be a sterile sample, we can clean the stoma and catheterize it and get a sample that way. We also have to think about our infants and children. So typically, if they're older than the age of 2, the nurse or the parent can help collect a urine sample just like you would an adult client. You may have to hold a cup or walk them through how to do it. For infants, we can use a collection bag. It's like an adhesive bag that they tape onto the genitals. It's almost like a diaper, except it's a bag that collects the urine. And then if that doesn't work, the provider, the NP or MD, can actually do something called suprapubic aspiration, where they take a needle and syringe and withdraw straight from the bladder. Of course, this would not be in the RN scope, but you might help assist with the procedure. And then finally, you may have something ordered called a 24-hour urine specimen. I do want you to be familiar with this because you may see it a good bit. So the way 24-hour urine specimens work is we are looking at the kidney function and urine production over a whole 24 hours. So if the client starts the test at 8 a.m. on Monday, they will complete it at 8 a.m. on Tuesday, not an hour before, not an hour after. It has to be exactly 24 hours. And you need to tell the clients if they miss a urine sample or if they stop too late or too early, that it will probably mess up the test and they'll have to redo it. So the way we teach them to do this is the first void they are going to void and get rid of. So we don't want to collect the first void because it has been sitting in the bladder and it's not an accurate measurement. So we're going to get rid of the first void, and then after that first void, we're going to collect any urine they produce from that point on for 24 whole hours. So it's usually a large jug that we put this urine in. They can either void straight into the jug or we can use a collection device and then pour it into the jug. Typically, this test has to stay refrigerated or on ice over the 24 hours. So make sure you check with the lab to see how they want that stored. But like I said, just make sure they know all urine they produce in 24 hours after that first void needs to be collected. You also want to tell them, especially if they're in the hospital, that there needs to be a sign on their door that lets everyone know that they are on a 24-hour urine test. And then once they have completed the 24 hours, they will void one last time, place that into the jug, and then send it to the lab. All right, so we've now learned how to collect the urine specimen. So now we're going to talk about what labs can we do with that urine specimen. So we're going to talk about some diagnostic testing that can be used for urinary function. So the first one we've already touched on, but it's urinalysis. So urinalysis is going to examine the urine sample to check for various substances. So it's essentially going to tell us what is that urine made up of. So it could tell us bacteria, protein, glucose, blood, ketones, drugs, electrolytes. It can test for various things depending on what the provider orders. We also can do a urine culture. So, a urine culture is going to examine the urine sample for the presence of microorganisms. That may be bacteria, that could be viruses, it could be fungi, different things like that. That is how we are usually going to tell if they have a urinary tract infection and how to treat it. We can also add something called a sensitivity to that, which will tell us if an antibiotic will kill the bacteria or not. I do want to mention here in the urine culture that does have to be a sterile sample. We can either do a clean catch or we can use an in and out catheter or get it from a Foley catheter. But we don't want this sample to be contaminated, so it does need to be as clean or sterile as possible. It's also important to note if you're going to be collecting a urine culture that you do so prior to starting any antibiotics because we want it to be the most accurate sample possible. So get your urine culture before you start antibiotics. We can also check specific gravity, which tells us the density of the urine. This can give us an indicator on how hydrated a client is. So we know if it is a higher number, that means the urine is more concentrated. So they would be dehydrated. So when you're dehydrated, your kidneys are going to hold on to fluid, so it's going to concentrate that urine. Versus if you're drinking a lot, you will become overhydrated and your urine will be less concentrated or more dilute is the other word for that. So higher the number, more concentrated, lower the number, less concentrated or dilute. So think about it if you have been drinking a ton of water and you're doing really well, your urine is going to be more clear, right? Well, that's dilute urine versus if you're not excuse me, if you're not drinking enough, maybe you're drinking a lot of sodas and not drinking water, your urine's going to be darker and that's more concentrated. So that's a way to remember that. There's also some blood tests we can do to tell us about our kidney function. So the blood urea nitrogen, or BUN, it is not BUN, it's BUN. It is a blood test that helps measure the urea nitrogen in the blood. So as the kidneys filter out blood, they're supposed to get rid of waste products like urea and nitrogen in our blood. If it does not do this, we know something is going on with the kidneys. We can also test a creatinine, which is another blood test that tells us about waste products in the blood. So we know if there's more waste products in the blood, something is going on with kidney function. So when the BUN and the creatinine go up, when they elevate, we know there is an issue with kidney function. There's also something called a glomerular filtration rate, or a GFR, which just measures how much blood passes through the kidney in a minute and how well they are filtering. Continuing on, we can do a urodynamic study. I've actually never seen this done, but your book does mention it. It measures how well the urine is flowing. So, just some reminders here. They do need to be NPO and have a full bladder, and then they will use a catheter during this procedure. A cystoscopy is a procedure where they use a scope to look inside the bladder and urethra. So what they'll do is they'll introduce a scope into the urethra and up into the bladder to see what's going on. So make sure you check your orders. They may be allowed to drink liquids. They may be NPO. They are going to use sedation, and then we need to tell them it is common to have some pain and blood in their urine after this procedure, and to drink lots of fluids to flush their bladder out after the procedure. All right, moving on to a couple more diagnostic tests. The IV pilogram, or intravenous pilogram, is a procedure where they inject dye into the IV and then use different x-rays to look at the kidneys and ureters. So some things you need to know as the nurse: anytime they are using dye, you have to assess for allergies to iodine and shellfish. Remember that you can't just say iodine. They may not know what that is. So make sure you say shellfish, because iodine is derived from shellfish. If they say yes, they have an allergy, you need to stop and make sure the provider knows. They will be NPO before this test. They usually get a creatinine blood test done before to check their kidney function. Because the dye can be very brutal on the kidneys, we don't want to send somebody with a bad kidney function for this test, because it will make it worse. They may have to take a laxative the night before or an enema the day of, and that is just to clear out their bowels so we can get a good view of the kidneys and ureter. They will need an informed consent for this procedure because it's invasive, and they do need to empty their bladder before the test. Once they're done, we want to encourage fluids to flush out their kidneys and bladder from all that dye they got during the procedure. A retrograde polyogram is essentially the same thing, except instead of using an IV, they insert a catheter into the urethra and inject dye through that catheter. So the same instructions apply. You still need to assess for the kidney function and any allergies, and then encourage fluids afterwards. The renal ultrasound, we know an ultrasound is non-invasive. All they're going to do is use an ultrasound wand to look at the kidneys and the see how well the blood vessels and the kidneys are functioning. So they can usually eat or drink before this procedure, and there's usually no special instructions. And then finally, of course, we have a CT scan. That's just a special radiographic procedure that examines the body part. It's usually the abdomen and pelvis for urinary problems. They do need to be NPO before this test. And if it's going to be a CT with contrast, we would assess for those same iodine and shellfish allergies. Keep in mind, anytime you have a patient going for a CT or MRI, they could be claustrophobic or have anxiety from that test, and they may need a sedative. All right, so we've talked a lot about how to diagnose urinary problems, but how do we actually prevent them or promote elimination? So, as the nurse, we do want to always try to prevent problems, right? So, some ways we can promote urinary elimination. Well, we want to encourage them to maintain their regular voiding habits. If they're in the hospital, we know that we mess up their schedule, everything's going to be off. So we do want to encourage targeted toileting. That means getting them up and going to the bathroom every 1 to 2 hours. We need to encourage them to go when they feel like they have to go. Do not hold your urine in because you may lose the urge to go. So just like we would tell a child, we're going to tell them to go when they feel like they have to. We're going to offer them privacy and we're going to make sure they are getting the proper hygiene and they're in a comfortable position to go. Just like you would do at home, you're going to wash your hands after the bathroom. We want to offer them that as well. Even if they're bedbound, we can offer them a wet wipe, hand sanitizer. We want to keep it as close to their normal routine as possible. Of course, we also want to promote fluid intake. So everyone should be drinking 8 ounce glasses of water a day, or fluid, preferably water. We also want to give them their favorite fluids, so that might be fresh water with ice, juice, things like that. But we do want to avoid anything that's going to irritate the bladder. So, some bladder irritants include caffeine, alcohol, high sugar, and high sodium drinks. So, that's going to be your soft drinks, of course. We do want to remind our cognitively impaired patients to drink. So every time we're rounding on a patient who may have dementia or some kind of issue where they can't remember to drink, we want to encourage fluids for them. And then if they're having trouble with nocturia, where they're getting up at night to go to the bathroom, we're going to decrease their fluids right before bed to help with that. If it's a problem with incontinence, which we'll learn about more in another slide, we can encourage pelvic floor training, which are Kegel exercises. It's essentially where they bear down and hold on for 5 to 10 seconds and then relax. And this strengthens the pelvic floor to help bladder function. And then finally, of course, as the nurse, we do have to assist them to the toilet. Always think about safety. Falls are a huge problem when it comes to going to the bathroom. So if you have a high fall risk patient, you have to stay with them at all times. Now, that doesn't mean you can't give them privacy. You can stand by the door, but you need to be close enough to watch them and be an arm's length away if at all possible. We can also remember to use privacy. That might be pull the curtain, pull the door, get the bedside commode as close by as you can get it so they can get up and down easily. And then we can offer them a bedpan or urinal if they're bedbound. But once again, remember privacy. If you have family members or other people in the room, ask them to step out while the patient uses the bathroom. All right, we're going to talk about urinary devices on the next few slides. The first device is the external catheter. So, an external catheter adheres to the genitalia and collects urine without having to actually enter the body. So, it is an alternative option to an indwelling catheter and it decreases the risk of our CODIs or our catheter associated infections. So the first one is known as the external urinary sheath. It's also called a condom cath. So it is used exclusively for our male clients. Some things as the nurse you need to know is you have to assess for a latex allergy and you do have to measure because there are different sizes. So usually the condom catheter kit will come with a measuring device that you use before selecting the size. So in order to apply it, you do have to clean the penis. If they are uncircumcised, you have to retract the foreskin, clean really well, and then you will bring the foreskin back up before you apply it. So you will apply it just like a condom. It goes down the shaft of the penis and it has adhesive on the inside to keep it in place. Make sure that when you apply it that you leave 1 to 2 inches beyond the tip of the penis so that the urine can drain properly. You don't want it to be so tight that it restricts their blood flow or causes discomfort. We have to assess the skin frequently. You may have to shave the client if they have a lot of hair. And then remember, you're going to attach it to a collection or a leg bag and let it drain by gravity. So it does need to stay below their bladder. This is a device that has to be removed daily. You have to wash and clean and then reapply a new one. When they work, they're great, but sometimes they don't adhere well, and then you have a big mess on your hands. So make sure you're assessing it frequently to make sure it's not leaking because it can cause skin breakdown if it leaks. And then we have an external urine collection system called the PureWick system. They make them for males and females. So it is actually connected to suction and wicks away urine so the patient does not stay wet, which is good for skin integrity. The female, excuse me, the female client, this will be in between their labia against their urethra. And the male client, it is a pouch that you insert the penis and then it adheres to the pubic area. You're going to clean the area per the directions of the package and then apply it to low continuous suction. And then you'll change it daily or as needed. All right, so this is just a slide showing you some different pictures. We see the condom cath here in the upper left corner. They have it attached to a leg bag, but you can also attach it to a Foley collection bag. Just make sure that it remains below the bladder. And then the rest of these pictures are pictures of the PureWick system. It is connected to suction. They can get it for home use and actually have a suction device connected to it. Of course, if you're in the hospital, it will connect to the wall suction. But the blue one up here on the upper right is the female, and then on the lower right is the male option. All right, so we're going to continue on with urinary devices and talk about catheters. So, a catheter is a device that's inserted into the bladder to drain urine. As a nurse, it is within your scope of practice to insert urinary catheters. You must remember that it has to be through sterile technique. So, whether it's an in and out or an indwelling catheter, you have to uphold sterility during the procedure. You also need to assess for latex allergies. A lot of catheters are made from latex, so make sure that you know that prior to inserting. And they do make silicone or other materials if they're allergic to latex. It's sized on the French scale. Typically, the sizes for an adult range from 12 to 16 French. Of course, you want to choose the smallest catheter possible to prevent trauma. If you get in the room and the catheter will not go in, you may need to go down on the sides. And then if it's an indwelling catheter, it will have a balloon attached to it, and the balloon will hold anywhere from 5 to 10 milliliters of saline to hold it in place. It's important to know that catheters are a high risk of infection in the hospital. It's actually the most common cause of healthcare associated infections. So that means that we are actually giving these clients infections the longer these catheters are left in. It's called a CAUTI, a catheter associated urinary tract infection. So, in order to prevent CAUTI, some of the things nurses need to do, make sure we're inserting it with sterile technique. We're cleaning properly, making sure that catheter stays below the bladder. And then we also want to make sure that patient or that client has a valid use for the catheter. If they do not meet the guidelines to have the catheter, then we need to get it out. And that is within the nurse's assessment to make sure every day that they are asking why this patient has the catheter and is it time to remove it. Some of the reasons that are valid for having a catheter include urinary retention. So that means that they cannot urinate on their own, they're retaining urine. A neurogenic bladder, like after a spinal cord injury. Strict eyes and nose in the critically ill. So this would be like an ICU patient. Sacral or perineal wounds, to make sure that those wounds heal properly. Sometimes we have to put a catheter in to keep that wound clean and dry. Surgical procedures, end of life care, that would be a comfort measure for our hospice and palliative patients. Prolonged immobilization, so a trauma or fracture where they are bedbound for long periods of time, or to obtain a sterile urine specimen. Like we talked about earlier, an in and out catheter can be used to obtain a sterile urine specimen, but it should not be an indwelling catheter, just an in and out for that instance. All right, so we're going to talk about the different types of catheters you may see. The first kind is the intermittent or the straight catheter. It is a one lumen catheter. It is meant for one-time use only. You may also hear it called an in and out catheter because you put it in and then you take it right back out. It does have a lower risk of infection because it simply goes in, removes urine, and then it's taken back out. It might be used for bladder management. If you have a paralyzed patient, they might do this at home and self-cath themselves if they can't manage their bladder. It may also be used for urinary retention or for obtaining urine specimens. Like I said, it can be done at home. There is a box on box 38-6 on page 1475 that walks through how a patient can self-cath at home. Just be mindful that if they are doing this themselves, it will be a clean procedure and not a sterile procedure. And then we have the indwelling or Foley catheter. This is a double lumen catheter. One lumen is for balloon inflation, and then the other is for urinary drainage. So this is for longer periods of use, but it does carry a higher risk of infection because it stays in the bladder. If a straight tipped Foley catheter will not work, we can use something called a Coude catheter, which has a curved tip that allows it to pass through an enlarged prostate or a blockage. So you may see this type of indwelling catheter used in your male clients that have prostate problems. And then we have the three-way catheter, which has three lumens. One will inflate the balloon, one for urinary drainage, and one for bladder irrigation. So this is commonly used in our clients who are post-op urology surgeries and need irrigation to prevent bleeding and blood clots. I have some pictures of that coming up. And then we have a suprapubic catheter. This is a indwelling catheter that's inserted through an incision above the pubic area and then inserted in through the bladder. So this is a surgical procedure and it is used for long-term continuous drainage. So it's going to divert the urine away from the urethra and drain straight from the bladder. This is used a lot in our paralyzed patients, spinal cord injuries, people that are going to need a catheter for a long period of time because it does decrease the risk of infection. All right, so this slide just shows you some different types of catheters you may see. So in the upper left is the suprapubic catheter. So we see that it diverts away from the urethra altogether and is inserted through a small incision into the bladder directly. So like I said, this is going to be for long-term use in our like spinal cord, maybe a stroke or a paralyzed patient. And then on the upper right, you see the catheter A is a straight catheter. So it's just what we call an in and out. It essentially goes in, removes the urine, and then comes right back out. And then B and C are both types of indwelling catheters. B would be your actually a silicone catheter, but it is a straight tip. And then C is latex, but it is a coude. So you see how the tip is curved. That can be used to get around the prostate or any obstruction in the urethra. And then D is a triple lumen or a three-way catheter so that you can insert irrigation as well. Here on the bottom left is just a up close picture of what an indwelling catheter looks like. So this would be your standard Foley. It has two lumens, and one of them is to inflate the balloon that holds it in the bladder. And then on the bottom right, you see a self-cath kit. They can actually do this at home, and like I said, it would not be a sterile procedure. It would just be clean if they were doing it themselves. Right, so this slide is just going over some tips for inserting a catheter. You can review the skill in your book. For the female, it is skill 38-2 on page 1493. And then for the male, it's skill 38-3 on page 1500. We will also spend time doing this in the lab, but I do want you to go ahead and familiarize yourself with the procedure. So some of the things you as a nurse need to know, remember it's always going to be a sterile technique. You want to provide privacy and make sure they know this is going to be an invasive procedure. For women, we want them to be supine with their legs spread apart and their knees bent if possible. Males can just lay in a supine position. And then typically the kit is going to come with everything you need, but make sure that it does include everything you need and the right size sterile gloves. You can switch out catheters if needed as long as you maintain sterility. So if you get a kit and maybe it's a latex kit, you can switch it out for a silicone catheter, or if it's a straight tipped and you need a coude tip, you can switch those out as long as you maintain sterility when doing so. And then some facilities may actually have a two-person policy, meaning that you have to have a second person in the room to help you maintain sterility. All right, now that we've got the catheter in, we need to know how to take care of a patient who has a catheter. So, one of the things you always have to remember is that the bag has to be below the bladder for it to drain properly. So, you got to think about gravity. So, if we want the urine to flow downwards, we have to keep it below the area that the urine is coming from. So, the bag has to stay below the bladder at all times. If it doesn't, it could actually cause reflux and the urine to go back into the bladder, and we don't want that. Always keep the drainage bag off the floor. That is just infection control. If we leave it on the floor, it's more likely to get contaminated and can cause the patient an infection. Always check for any loops or kinks in the tubing because if it is kinked off, that urine will reflux back into the bladder and it could cause pain or infection for the patient. Always make sure your connections are secure and that it's not leaking. You always want to keep a closed drainage system. So that means that you're not breaking the connections if at all possible, because once you break the closed system, you are more at risk of causing an infection. We always want to secure the catheter either to the leg or the thigh. This can be done through various devices. They make leg straps, stat locks. You just need something to secure that catheter so it's not moving everywhere. If it's moving, it has a higher risk of coming out. We also want to perform peri-care daily and as needed. So if they have a bowel movement, we want to make sure that we clean them well and always make sure we clean that area really well. A lot of places will actually have a policy in place that you clean them with chlorhexidine or a betadine, some kind of disinfectant. We always want to clean the catheter away from the body. So we're going to actually clean the tubing of the catheter and move in a downward motion away from the body. They are allowed to get up and move. They can shower like normal. Just always make sure that catheter stays below the bladder when they're up and moving. We want to empty the bag when it's 2/3 of the way full to prevent any reflux of urine. We don't want that urine going back up into the bladder. And there's also a risk that the bag could rupture or explode basically if it gets too full. And then we only want to change the catheter when it's ordered or when it's necessary. We don't want to constantly be reintroducing bacteria into the urinary system. And then, of course, remove the catheter as soon as possible. You, as the nurse, need to advocate for these patients. If they have a catheter and you don't think they do not need it anymore, then talk to the provider about getting rid of it. Or you may have a nurse-driven protocol at your facility, which tells the nurse if the client meets certain criteria, the nurse can pull the catheter out without an order. All right, so a couple of more things on caring for the patient with a catheter. You may be asked to irrigate an indwelling catheter. This is not very common. Usually, if they're going to be on irrigation, they will have something called continuous bladder irrigation, which is where you use the three-way Foley catheter and you connect it to saline bags. But if that is not the case, you may be asked to irrigate it with a syringe. So essentially, that is to remove an obstruction or to put medication directly into the bladder. You do need to know this is going to break the closed system and increase their risk of infection. So it is not preferred unless it is ordered to do so. But what you would essentially do is detach the catheter from the tubing and fill a syringe up with medication or saline, irrigate the bladder, and then either let it drain or pull it back out to remove whatever obstruction may be there. Usually it's a blood clot after surgery or something like that. But like I said, that is not preferred because it does increase the risk of infection. And then to remove a catheter, there are several things you have to do before you actually remove it. First, you want to see how big the balloon was that was inserted. So if it was a 10 milliliter balloon, you should get 10 milliliters of saline back out when you deflate that balloon. If you do not deflate the balloon all the way and you pull it out, it's going to cause a lot of trauma and pain for your patient. You want to empty the catheter bag and tubing of any urine and make sure you chart that as output. And then you're going to remove the catheter securement device, so the leg strap or the stat lock. Then you will deflate the balloon. Like I said, make sure that you remove all the saline from the balloon. And then you're going to ask the client to take a deep breath and gently pull the catheter straight out. You want to go quick, but not too fast, just a steady rate. And then you'll clean the perineal area post removal. And then make sure the patient knows that there may be a little bit of blood and some pain after catheter removal. This is normal. Also tell them that they may be incontinent until their bladder is able to regain control because it kind of got lazy and kind of stopped controlling the urination, especially if they had that catheter in for a long period of time. You do need to note the time you removed the catheter and make sure you chart that because it is important to know the first time they urinate on their own after that catheter was removed. If you do not see any voiding after 8 to 10 hours, there might be some urinary retention going on, and you need to make sure you let the provider know. Right, so we're going to go ahead and start on our first exemplar, which is urinary incontinence. So, incontinence essentially means it's the loss of control of the bladder. So, a normal, healthy individual is able to control their urinary sphincter and can hold their bladder until they get to a place where they can release it. If you have a patient with incontinence, they may have involuntary leakage of the bladder, meaning that they can't always hold their urine. So it is a symptom of a disorder and not a disorder itself. So usually if we can find the underlying cause of the disorder, we can correct or manage it. It is more common in middle-aged to elderly females because they lose a lot of bladder muscle with age, menopause, childbirth, etc. And it's important to note that it can be very embarrassing and uncomfortable for the patient because they may end up having an accident where they cannot get to the bathroom. We're going to talk about the different types on the next slide. All right, so there are various different types of urinary incontinence. I do want you to be familiar with these, but do note I put stress incontinence in red because it is the most common that you'll see. So I'm going to go through the different types and I'll spend a little more time on stress incontinence. So we have transient incontinence, which comes on suddenly. This is usually caused by an illness or a medication. So when you think about medications, think about diuretics. If we're treating a patient with diuretics, they may suddenly have transient incontinence. I'm going to skip stress and come back to that. Next, we have urgency, which is a loss of urine that comes on as soon as they feel the urge to void. So they might get the urge to void and immediately go and don't have time to get to the bathroom. We have mixed, which is a combination of stress and urgency incontinence. We have overflow, which is a loss of urine due to overdistension of the bladder. That one's not very common, but it essentially happens the bladder overfills and the patient loses control of it. Functional is a loss of urine caused by the inability to reach the toilet because of environmental factors. So, functional is going to be environmental. So, they might be physically impaired. They may not remember that they need to go to the bathroom if they're cognitively impaired, or if something is in their way, like furniture, a bedside table, maybe they trip and fall, things like that. That would be functional incontinence. Reflex incontinence is emptying of the bladder without sensation to void. So this may happen in our spinal cord injuries, radiation damage, neuro diseases. They basically do not feel the need to go to the bathroom. They don't have that sensation. And then total or continuous incontinence is unpredictable loss of urine. This may result from a physical malformation, trauma, surgery, spinal cord injuries. Essentially, they have no control of their bladder at all. It just drains continuously without any kind of warning. And then I want to hop back over to stress incontinence. So, like I said, this probably is the most common that you'll see, and it occurs because of weak pelvic floor muscles. So, think about childbirth, menopause, obesity, chronic constipation. These are things that can weaken the pelvic floor and cause incontinence. So, this is going to happen when they have an increase in intra abdominal pressure that causes more pressure on the pelvic floor, and then they have an incontinent episode. So, coughing, sneezing, laughing, lifting, changing positions, things that increase intra abdominal pressure, going to put more pressure on the pelvic floor and can cause those incontinent episodes. All right, so now we're going to talk about management of incontinence. There are several things as the nurse you need to do to help the client that is incontinent. So, the first thing before you recommend any therapy is to do a thorough urinary assessment. So, there are several things you need to know. You need to know how often are they having incontinent episodes? Is it a bowel and bladder, or is it just bladder? Do they use any absorbent products like pads or briefs? What's their skin integrity like? Because we know if they are sitting in moisture, they can have skin breakdown and excoriation in their perineal area. Do they use any kind of devices like those external catheters we talked about? Do they have equipment like bedside commodes, walkers? Is there anything that is getting in the way with their ability to go to the bathroom? Are they doing pelvic floor therapy and Kegel exercises? And are they on a targeted toileting regimen? Are they doing any bladder training? So once you've asked all of those questions, we can then start talking about the management of incontinence. So how can we treat or prevent incontinence from happening? So we know as nurses, the first thing we always want to do is promote behavioral interventions. So what can we do to help this incontinent patient? Well, we can recommend those absorbent products like pads, briefs, things like that, but we do want to make sure they know that comes with the risk of skin breakdown. So they do need to be changed frequently and kept dry. We can also recommend external collection devices like the PureWicks and condom catheters. We can work with therapy like physical therapy and occupational therapy to get them walkers, bedside commodes, whatever they may need. We can do some pelvic floor therapy and teach them Kegel exercises. We can put them on the targeted toileting schedule where they go to the bathroom every 2 hours. Fluid management. So if they're having trouble with incontinence at nighttime, we can decrease the amount of fluids they get before bed. We can also make sure they're avoiding any bladder irritants. Remember, those irritants are things like caffeine, alcohol, artificial sweeteners, sodas, things like that. And then if they are on a diuretic, we want to make sure they take it before 4 p.m. Ideally, they need to take it in the morning, but if it's ordered for twice a day, they definitely need to take it before 4 so that they're not up all night going to the bathroom. And then finally, there are more invasive interventions we can do. There are bladder stimulators, pessaries, which is just a device that helps hold the bladder up. There are different surgeries they can have, and of course, medication therapy. All right, so we're going to go ahead and talk about some medications that are used for the management of incontinence. Remember, medication is second line therapy, so we don't use them until we've exhausted all those behavioral interventions we talked about. But if they fail, we may need to add some medication. So one of the medications that you may hear about is amitriptyline. It is an antidepressant. It is an older antidepressant. It is a member of the tricyclic antidepressant class. But what it does is it decreases bladder contractions. There are quite a few side effects with these older generation antidepressants, such as dizziness, drowsiness, weight gain, and constipation. So they're not used as commonly as they used to be. It's also important to remember amitriptyline can discolor the urine green, so you need to make sure you tell your client that as well. If you have a client, a female client that's postmenopausal, they may give them estrogen supplements. The reason they do this is because as the woman ages and they go through menopause, they lose or stop producing estrogen, which can break down and cause atrophy of the vaginal and bladder or pelvic muscles and tissue. So what they'll do is they'll give estrogen through a vaginal suppository to help build some of that muscle strength back. One of the medications I really want you to focus on for this is our anticholinergics. So just to do a brief little remediation in A&P, if you remember, acetylcholine is a neurotransmitter released by the brain. And what acetylcholine does is it activates our muscle function. So when we have an anticholinergic, that is essentially anti-acetylcholine. So it blocks acetylcholine and prevents some of the symptoms of incontinence. It also is going to dry everything up. So it's going to stop bladder contraction and dry everything up. So you're going to have dry mouth, constipation, dry eyes, and blurry vision. The most common one you'll see for incontinence is oxybutynin. If you look under this, I also have anti-muscarinic agents. They are essentially the same as they are a type of anticholinergic. So when you think about anti-muscarinics and anticholinergics, you can think about them as one and the same. And oxybutynin is going to be the main one for both of those classifications. And then there is one newer medication called mirabegron. It is also known as Mubettrick. It works on overactive bladder by relaxing the bladder muscles. You don't have to focus so much on that one, just know that it exists. Some of the side effects include headache, hypertension, and dry mouth. Like I said, the main one you're going to see most often are those anticholinergics, especially oxybutynin. So be very familiar with that one. All right, so our next exemplar is urinary retention. And when you think about urinary retention, I want you to think it is essentially the opposite of urinary incontinence. So, urinary retention essentially means you're unable to release all of the urine in your bladder. It can result from several disorders: diabetes, prostate problems, urethral disorders, trauma, pregnancy, neurological disorders. There are many things that can cause it. It can also be the side effect of a lot of medications. So, what will happen is the patient will say that they feel as if their bladder's full, or they'll go to the bathroom and feel like they didn't empty their bladder all the way. And the way we diagnose this is by doing a post void residual, which is where we have the client urinate as much as they can, and then we either bladder scan them or we can catheterize them and see how much urine is left in the bladder right after they urinate. According to your textbook, if it's greater than 50 to 100 milliliters, that is considered retention. All right, so let's say that you have a client who says they are urinating and they feel like they just can't get everything out. They still feel like their bladder's full. So you would have them urinate and then you would immediately bladder scan them and see how much urine was left in the bladder. Well, let's say you did that and there was 100 milliliters left in the bladder. So that would be considered urinary retention. So, what do you as the nurse need to do for that? Well, that first of all, you always need to do your urinary assessment. You need to ask them how often are they voiding, how much are they going, are they experiencing dribbling, pain, discomfort? Do they feel like their bladder's distended? And then also something you have to think about if you have a client that maybe has a cognitive deficit and can't tell you that they are having urinary retention, they may become restless and agitated. So you may see these clients that have had a stroke or dementia who aren't able to verbalize that need. They may become restless and agitated as they can't empty their bladder. So that is something as a nurse you may want to bladder scan them and see if that's a reason for their agitation. So, once we've done our assessment, the first line therapy is again behavioral interventions. So, our goal is to prevent over distension of the bladder and correct whatever the problem is. So, we don't want the bladder to become over distended because it can cause reflux back into the kidneys, it can lead to infection, and the bladder can actually rupture if it becomes too full. So, some of the things the nurse can do, we want to encourage normal voiding patterns. We don't want to ignore the urge to go to the bathroom. We don't want to hold it if at all possible. We want to encourage a comfortable environment and a private environment for them to go to the bathroom in. Some people have really shy bladders, as we call it, so they may not want the nurse staring right at them while they try to urinate. So try to give them as much comfort and privacy as you can. You can also apply warmth to relax the sphincters. So one of the things you can do is pour warm water over their abdomen and pelvis, or offer warm beverages like warm tea, warm milk, things like that. You can turn on running water. Sometimes the sound of running water will help someone relax and go to the bathroom, or you can dip their hands in warm water. If none of those interventions work, we will move on to more invasive stuff. So you may want to do a bladder scan to see how much urine is left in the bladder after they've tried to go to the bathroom. And then if there's still urine in there and they are unable to void on their own, we would probably need to do a straight catheterization. That's the in and out cath that we talked about earlier. We can also start to initiate bladder training to help retrain the bladder, where we take them to the bathroom every so often and set up a schedule. And then, of course, there's medication therapy that we can do as well. All right, so your next exemplar is benign prostatic hyperplasia, commonly known as BPH. So it is a non-cancerous, so it is not malignant enlargement of the prostate, and it is one of the most common disorders in men older than 40. So it is important to know that this is something that can only happen in the male client, as the female does not have a prostate. So what happens is the prostate becomes enlarged, it becomes inflamed, and it can actually obstruct the bladder and the urethra, which ultimately causes blockage and urinary retention. And then all that urine is going to back up, and it might actually end up backing up into the ureter, which is called hydroureter, or into the kidney, causing hydronephrosis, which just means fluid on the kidney. It can also lead to a urinary tract infection because that urine is just sitting in the bladder and can ultimately, bacteria can start to grow in there. So, some of the risk factors, of course, male over the age of 40, smoking and alcohol use, obesity, reduced activity, hypertension, heart disease, diabetes, and a Western diet. A Western diet is going to be a diet that's really heavy in animal fat. All right, so you see in this picture here, we have the patho of BPH. So you'll see up here in the upper left, you have a normal prostate and bladder. So normally the urine would drain from the bladder into the urethra, and the urethra actually runs through the prostate of a man. So at the bottom right, you can tell this prostate is very enlarged and inflamed, and it's so swollen that it actually blocks urine from leaving the bladder. So we could see how this could cause urinary retention, as the client may only be able to get out very small amounts of urine. All right, so we're going to continue on with BPH. So if you have a male that comes into the clinic and is having urinary problems, one of the first things you're always going to think about is prostate, especially BPH in our older men. Remember, men over 40 are at the highest risk. So some of the signs and symptoms: frequency, urgency, they may be getting up a lot at night to go to the bathroom. Hesitancy, which basically means they try to go to the bathroom and they're unable to start urinating. The stream of their urine may be decreased. They may feel like they're not emptying their bladder completely. They may have to strain to urinate. They may have dribbling or recurrent UTIs. The reason they'll have recurrent UTIs is because that urine is sitting in the bladder and can eventually start growing bacteria. And all of those symptoms make sense if you look at that picture on the last slide and realize that prostate is so swollen that it will block the urethra off. Therefore, they're going to have trouble going to the bathroom. They're going to feel like they aren't emptying their bladder. They may even have to strain to empty their bladder. So, if you think about the patho, it usually makes the signs and symptoms easier to understand. So once you have heard their signs and symptoms, you need to do a full urinary assessment. You need to ask them how often are they going to the bathroom? Are they waking up to go? Are they having to strain? We may do a post-void residual on them, which we have them urinate and then scan their bladder. We can also assist with a digital rectal exam. The RN themselves will not do this, but they may assist, and that is where a provider will digitally insert a finger into the rectum and feel for the prostate to see if it's enlarged. We may do a urinalysis to see what's going on with the urine, and we can also do a blood test called a prostate stimulating antigen. It's also known as a PSA, to rule out prostate cancer as well. So once we've made the diagnosis of BPH, our goal is to improve this patient's quality of life. Immediately, if they are retaining urine and unable to void at all, they're going to need a catheter. It may either be an in and out to drain the bladder, or the doctor may order an indwelling catheter until that prostate is not so swollen. Remember, if they are very swollen, you may have to use a Coude tip catheter to get around that prostate. You may also see they have a surgery called a TURP, or a transurethral resection of the prostate. This is where they go in endoscopically and remove part of the prostate through the urethra. So they won't remove the whole prostate, but just enough of it to prevent the blockage and reduce swelling. It is important to know that they usually will have that continuous bladder irrigation and that three-way catheter after this procedure. And then finally, there are medications we can give for BPH. The reason I didn't list medications in urinary retention is because they are the same. So our urinary retention meds and our BPH meds are usually the exact same. So one class of medication are alpha blockers. This is going to be your terazosin, your doxycycline, and your tamsulosin. So you see they all end in sin, S-I-N. Tamsulosin is probably the most common. It's also known as Flomax. The way these medications work is they relax the muscle of the bladder and prostate. And what they do is they relax it so the patient can void completely. And they also help to reduce swelling. Some of the side effects, they can get very dizzy on these medications, so it is very important to make sure you put these patients on fall risk and make sure they sit before standing and think about safety with these medications. It may also lead to some sexual dysfunction, so you need to make sure that your male clients know that. We also can give them 5-alpha reductase inhibitors. These are known as finasteride and dutasteride. What they do is they help prevent the conversion of testosterone to DHT. So DHT is a hormone that is known to enlarge the prostate. So this medication works by stopping that from happening. And what it does is it decreases the size of the prostate. Some of the side effects, again, can affect sexual function. It can cause erectile dysfunction. It can cause gynecomastia, which is enlarged breast in men, and flushing. It's also important to know that both of these BPH medications can be hazardous. So usually your pharmacy is going to tell you to wear gloves while administering these, especially your female and pregnant clients. We definitely want to wear gloves if using and giving these medications. All right, so this slide is just a picture of the TERP procedure that we talked about. Here on the right side, you'll see what a normal prostate looks like. And then in the middle, you see an enlarged prostate. And then on the end here, you see after the TERP. So what they do is they went in through the urethra and shaved off part of that prostate so that the urethra can drain the urine properly. And then over here on the left side, you'll see continuous bladder irrigation. So I do want to talk about that for a moment. Remember, it's got to be done through a three-way catheter. Remember, one lumen is going to inflate the balloon, one is going to drain the urine, and one is going to be hooked up to irrigation. So your tube will enter the bladder. You will have one of them draining the urine into the bag down here. You'll have the other one that just is for the balloon, and then you'll have a third tube that gets hooked up to the irrigation. The irrigation is typically saline bags. They're just larger saline bags than what we use for IV therapy. And it is connected to tubing, just like IV tubing. It has a drip chamber and a clamp to control the rate. So usually the rate is controlled by the nurse, and usually your order will say to irrigate to light pink. So a lot of people will call this pink lemonade. So we don't want the urine to be dark red or have clots in it. Ideally, we want it to turn back to yellow, and as the patient continues to heal, the bleeding will stop and they should turn back to a yellowish color. But for the first 24 to 48 hours after this TERP procedure, they are going to have pink to red urine. So usually the goal is going to be to titrate to pink lemonade. So if you come into the room and you're assessing your client and you see this bag is full of dark red or clots, you would want to increase the flow of the irrigation until you saw that pink lemonade color come back. It is not abnormal to see clots and a lot of blood after this procedure. So don't be alarmed by that. That is very normal. Typically, the provider would just tell you to increase the irrigation. It's also important to know that these bags run out very quickly, especially if you have it wide open. So you have to keep a very close eye on this system, or else it will dry out and will cause the bladder to, or the prostate to clot off, and then you'll have a lot of issues on your hands and it'll be a lot harder to fix. So always make sure that you keep extra bags in the room. And there are systems where you can hang two bags at once to help having to go in the room so often. But I'm telling you, I've taken care of these clients. Sometimes you're in these rooms every 10 minutes changing these bags out if it's wide open. Also, I want to talk about how you calculate urinary output with these clients. So, you have to think about the fact if you're irrigating the bladder, everything you put in there is going to come back out. So you have to take into account how much irrigant you put in. So if you put in 1,000 milliliter bag of irrigation, and then you go to empty your bag and you have 2,000 milliliters in there, the way you determine the urinary output is to take 2,000 minus the 1,000 milliliters of irrigant you put in, and that would give you 1,000. So that means that 1,000 was urine, 1,000 was irrigation solution. And that's important because that can tell you the difference between the irrigation solution and how much actual urine output the client is having. All right, so our next exemplar is urolithitis or nephrolithitis, which is just kidney stones. These stones can be found anywhere in the urinary tract. They usually originate in the kidney and then move down. Sometimes, if they are too large to move through the smaller parts of the urinary tract, they will get stuck. These stones can be made out of different substances such as calcium, struvite, uric acid, cysteine. There are many different types, but essentially what happens is these substances build up in the blood or the urine and cause these stones. So calcium oxalate are the most common, and they can be caused by an increase of calcium or vitamin D in the diet or foods that are very high in oxalate. We're going to talk more about those foods in an upcoming slide. Struvite stones are not as common. They're usually caused by infections. Uric acid stones are going to be caused by an increase of uric acid in the blood, and this is common in our gout patients. And then cysteine stones are very rare. It's actually caused by a rare disorder that causes cysteine in the urine. For this lecture, you guys are mainly going to focus on calcium oxalate and uric acid, as those tend to be the most common. But you may also see a struvite stone if a client has an infection. Some of the risk factors are going to be males are more likely to get them. Of course, if you have a urinary tract infection, you're at a higher risk. Urinary stasis and immobility. So, if we're not emptying our bladder, if we have bladder retention, or if we are immobile, all of those things can lead to it. Dehydration, of course, we know if we're not taking in enough fluid, that increases our risk. And then any disease that causes an increase of calcium in the blood or uric acid in the blood. All right, so what do kidney stones present like? Well, usually the number one symptom is going to be pain. It's usually going to be pretty severe pain in their lower back or flank area, which is where the kidneys live. We call it a colic-like pain because the pain will come and go in waves as the stone is moving through the urinary tract. So they may say that the pain is really severe and then it stops and then it starts again. And that is a result of the stone making its way through the urinary tract. They may also have a CVA tenderness. The costovertebral angle is a spot near the ribs. It's usually below the shoulder, um, in between the ribs, and it sits above the kidneys. So if you tap there or palpate there, they will have tenderness. You may also see hematuria, which is blood in the urine, nausea, vomiting. They may have the urge to void, but be unable to pass a lot of urine. If there's an infection involved, you may also see fever, chills, and urinary frequency. Kidney stones can lead to hydroureter and hydronephrosis, and even renal failure if the stone obstructs the urethra or ureter. I'll give a real life story here. I had severe pain in my lower back several years ago. I went to the clinic, got a CT scan, and I had a kidney stone stuck in my ureter. It was too large to pass, so it was actually causing fluid and urine to back up into my kidney. And they checked blood work, and my BUN and creatinine were elevated. So that's a good example of how a stone, if it gets stuck, that urine and fluid have nowhere to go. Therefore, it has to back up and can cause a lot of problems. So, how do we diagnose a kidney stone? Well, CT is the ultimate diagnostic test. We do a CT of the abdomen and pelvis, and we can actually see the stone on the CT. That'll also tell us how big it is and if it can be passed on its own or if the client is going to need a procedure to help it pass. We can also do a urinalysis that may show blood. A renal function panel, and then we can do like a uric acid, calcium level to find out what kind of stone we're dealing with. Once the stone is removed, if it has passed, then we do send it to the lab to determine what type of stone it was, so we know how to tell the patient to prevent them from coming back. Because based on the type of stone, that's going to change the kind of teaching and diet we recommend to our patient. So, what is our treatment options? So, the goal for treatment is to pass the stone, preserve renal function, and control the pain. So, pain management is a big deal with kidney stones. They are usually very painful. So, it's important that we keep our patient comfortable and we're doing our pain assessments. Remember, if we give pain medication, we always have to reassess for pain. Typically, if we're giving IV meds, we're going to reassess in 15 minutes. If we're giving oral medication, we're going to reassess in an hour. We're also going to teach them to strain the urine, so we can send them home with a urine strainer and to pee in it so that they'll know if they catch the stone, then they can bring it in and we can send it to the lab. You still want to strain it if they're in the hospital too, so you can know if they've passed it. If it's stuck or it's too big to pass, they can do some different procedures. One of the most common being lithotripsy, which is where they use shockwave therapy and it gently shakes the patient, and those shock waves break up the stone and they're able to pass it in much smaller pieces. They can also go in endoscopically and remove the stone. They can use laser therapy, or they can do an open surgery called a nephrolithotomy, where they actually go in and manually remove the stone. All right, so as the nurse, what are you going to do for kidney stones? Well, one of the most important things we teach is increase our fluids. We want these clients to drink a ton of water. Water, cranberry juice, any kind of clear liquid that is not a bladder irritant. So 3 to 4 liters a day is what we want these clients drinking. If they have an infection, we need to treat that very quickly with antibiotics. Like I said in the previous slide, we're going to strain the urine and they need to report any stones that they pass so that we can send those to the lab. Like I said, we're going to manage the pain very closely because this is a very painful diagnosis that they are going through. And then we do want to educate on nutritional therapy. So, based on the kind of stone they had, it will limit what they can eat in their diet. So, if it's a uric acid stone, we're going to limit something called purines in the diet. That also goes for a gout patient as well. Cysteine stones, we're going to limit protein in the diet. And then calcium oxalate, we're going to limit oxalate in the diet. And I do have some examples coming up on the next slide. All right, so what kind of diet do we want to put our kidney stone patients on? Well, that's going to depend on what kind of stone they've had. So that's why it's very important to catch or strain the urine, catch the stone, and send it to the lab so that we can educate our patient on what to avoid in their diet. So if they have a uric acid stone, we are going to encourage a low purine diet. So purines are a type of substance that break down into uric acid in the body. So when we talk about purines, we're going to think organ meats, red meats, so liver, things like that, shellfish, and alcoholic beverages. So beer and alcohol are going to be purine type foods. And then when we're talking about oxalate, those would be our calcium oxalate stones. So oxalate is a molecule we eat in certain foods, which by itself is fine, but what happens is it binds to calcium and can cause calcium oxalate stones. So foods that we want to avoid are going to be our spinach, our sweet potatoes, legumes, baked potatoes, beets, rhubarb, pumpkin, eggplant, and grapefruits are several that we want to avoid. So just be familiar with a couple of examples for these diets. I don't expect you to know every food in this section, but if you were to have to educate a client on what foods to avoid, I do want you to be familiar how to teach those clients. So this is the end of the urinary elimination lecture. I hope you guys got some good information from this. And if you have any questions, feel free to reach out. Thank you.